We'll start from the esophagus and we'll end in the rectum and anus. Oral cavity is mostly concerned mostly of the other specialties, but now we'll discuss from esophagus to the anus. So as you know, the gastrointestinal tract has various segments starting from esophagus, stomach till rectum and anus, and each one has its own function. But the key functions altogether are digestion, absorption, and excretion, although there are other specialized functions. So, coming to the esophagus, the commonly encountered disease which we routinely see is the gastroesophageal reflux, which is called GERD. And the etiology is multifactorial. The main indication of biopsy is to not to prove that there is GERD, but to exclude other types of esophagitis. But however, there are some characteristic features of GERD. For example, when you look at the biopsy, properly oriented biopsy, there is elongation of papillae, which may be more than 50% of the squamous epithelial thickness. And particularly among all the layers of the esophagus, there is basal cell hyperplasia. The layers range from 5 to 6 layers to more than 15% of the thickness of the squamous layer. In addition, you may get a mild increase in intraepithelial eosinophils with dilated intercellular spaces, which we call intercellular edema. And we may also get increase in lymphocytes that can be keratinocyte evacuation, vascular leaks, balloon cells, and so on. Whenever you get neutrophils, it is probably an indicator of a very severe acute gastroesophageal reflux. So this is what I was mentioning. There is a marked increase in the thickness of the squamous epithelium, increase in the thickness of the papilla, and the thickness is more than the basal layer thickness. Here, for example, this is the basal layer, and the thickness of the basal layer, as you can see, from 5 to 6 layers, it is more than 15% thickness. Right. So we may also have the other features such as these are nothing but keratinocytes. Squamous epithelial cells. Okay, and you find some spaces in between the keratinocytes. This is nothing but the intercellular edema. There can be increase in intraepithelial lymphocytes, as you can see here. And whenever we get eosinophils, we have a differential diagnosis between an eosinophilic esophagitis versus GERD, because both the conditions can show eosinophils in the epithelium. How to differentiate between the two? There are certain features. For example, in GERD, the eosinophils are randomly distributed within the epithelium, and usually they are less than 15 eosinophils per high power field. There should be absence of eosinophilic microabscesses, and there should be absence of eosinophilic degranulation. If these features are exactly the opposite, think about eosinophilic esophagitis. In GERD, the features are more pronounced in the distal esophagus, because that is the first point of entry of the reflux contents. So the distal esophagus is going to give you the maximum findings, whereas in eosinophilic esophagitis, the entire thickness can show these findings. So what is the natural course? The GERD can have no erosion, where it is called as non-erosive esophagitis, non-erosive reflux disease. It can just be a passive disease, or it can form erosions where you can have inflammation, and in that condition we call it an erosive esophagitis. So when the erosion heals, it may heal with squamous lining, or it may change the phenotype of the lining, wherein we may get either a columnar lining or we can get goblet cells. So it depends upon the type of cells, which where we call just a columnar line esophagus or a Barrett's esophagus, and this I will be discussing later. So why we are more concerned about Barrett's esophagus is because Barrett's esophagus is a metaplastic condition, and not only a metaplastic condition, it is a pre-malignant condition, because the metaplastic columnar lining epithelium is going to become dysplastic, and later on it is going to become fat malignancy. So endoscopically, what you are going to look at is a salmon pink mucosa that extends above the gastroesophageal junction into the tubular esophagus. And as I said, it is a metaplastic condition, and the normal stratified squamous epithelium which resides in the distal esophagus, it is going to be replaced by metaplastic columnar lining epithelium. So non-neoplastic Barrett's esophagus is nothing but the columnar lining esophageal lining that can be gastric funding, or it can be cardiac, or it can be intestinal type. So among the various type of cells, whether it is gastric fundic type of columnar lining, or whether it is cardiac type of columnar lining, or whether it is an intestinal type of columnar lining, the intestinal type has been clearly shown to predispose to cancer development. So according to the American and Australian guidelines, columnar lining esophagus without the presence of intestinal metaplasia alone is not considered as an indication for surveillance, as it doesn't satisfy the diagnostic criteria for Barrett's esophagus. Whereas the definition in UK is quite different. Irrespective of the presence of intestinal metaplasia, the guidelines for the UK is these patients undergo surveillance. So this is what I was talking about. This is a stratified squamous epithelial lining here, and we have a stratified squamous epithelial lining here. But here we find a columnar lining, which means the normal stratified squamous epithelial lining has been replaced by another phenotype that is called as intestinal, that is called as metaplasia. So as I said, metaplasia can be of different types. What metaplasia we are concerned about is the columnar lining epithelium with presence of goblet cells, which we call intestinal metaplasia. So you know this is a wine goblet, and these cells appear to be assuming the shape of a wine goblet. That is why these cells are called as goblet cells. Okay. So when you find goblet cells, it means there is intestinal metaplasia. And when there is intestinal metaplasia in an esophagus, you call it Barrett's esophagus. Okay, so as I was discussing about the British guidelines, the British guidelines are concerned over sampling error, and smaller studies have suggested equal risk with columnar lining epithelium, and hence current British guidelines do not require intestinal metaplasia for a diagnosis of Barrett's esophagus. And what do they do is they recommend surveillance in all patients with intestinal metaplasia, or when there is a report of columnar lining epithelium without goblet cells, and the columnar lining epithelium exceeds more than or equal to 3 centimeters. So it depends upon where you practice, and the entity of Barrett's esophagus varies, right? And the surveillance criteria also varies. So as I said, and as I showed you, intestinal type of columnar lining epithelium is defined by the presence of goblet cells, and in most experienced gastrointestinal pathologists solely rely upon the H&D stain, and there is not necessary that you need special stains to pick up goblet cells. You don't need any special stain. It is only a morphological criteria. Goblet cells can be cleared easily. So now till now we were talking about non-neoplastic or a metaplastic Barrett's esophagus. Now, what is a neoplastic Barrett's esophagus? Neoplastic Barrett's esophagus is nothing but the metaplasia has progressed to either a low grade or a high grade intraepithelial neoplasia, which we call dysplasia. So since it is confined to the epithelium, it has not crossed the basement membrane. It is non-invasive. So these conditions are called as non-invasive conditions. Whereas once it crosses the basement membrane, if it crosses the submucosa, they are considered to be invasive carcinomas. So till the submucosal level, they will be considered to be intramucosal carcinoma, that is IMC. And in late stage, it can be either a T2 or a T4 stage, depending upon how much invasion is there. So in histopathology, there is no single pathognomonic feature for dysplasia, but there are a combination of features. For example, lack of surface maturation, abrupt transition, and full thickness cytological atypia is common in dysplasia. In contrast to reactive atypia that only involves the surface, the full thickness dysplasia involves multiple layers. Okay. So then you need to look at stratification. So depending upon that, there are two major types of Barrett's esophagus related dysplasia. One is intestinal type of adenomatous Barrett's dysplasia, or gastric type, also referred to as non-intestinal type of adenomatous or foveolar type of Barrett's gastric type dysplasia. So low-grade intestinal phenotype, there is abrupt atypia, there is lack of surface maturation of the mucosa. Columnar line cells will be crowded, stratified. Sometimes they appear to be having a penicillate morphology. Nucleus will be hyperchromatic, and they resemble dysplastic epithelium of the tubular adenoma. And there may not be loss of polarity of these cells in a low-grade dysplasia. Whereas, yeah, so this is what I was talking about, the low-grade dysplasia. See, you can find, still the goblet cells are here, but from here, look at the cell size. So these are all small cells with small nuclei, which are poorly placed. As it progresses to dysplasia, the nuclear morphology alters. There is elongation of nuclei, coarse chromatin, the nuclei will become prominent. However, the layering is only single, so this is a low-grade dysplasia. So, low-grade dysplasia, non-intestinal type is cuboidal to columnar cells with mild to moderate nuclear atypia, minimal or no nuclear stratification, abrupt atypia, and lack of surface maturation. Often they lack goblet cells. So, this type I showed intestinal type because you also have a goblet cells. Whereas in non-intestinal type, you don't have goblet cells, but still they are dysplastic, and it is low-grade dysplasia. It is usually difficult to distinguish from metaplastic gastric foveolar epithelium since the grade of dysplasia is low. In high-grade dysplasia, there is abrupt atypia, lack of surface maturation, marked cytological atypia, complex glandular architecture. There is marked loss of nuclear polarity. So this is a reliable criterion to distinguish low-grade dysplasia from a high-grade dysplasia. So if you find this feature, that is marked loss of nuclear polarity, it is very likely that we are dealing with a high-grade dysplasia. So for invasive carcinoma, it is nothing but you have all the features of a high-grade dysplasia, but there is also invasion into the underlying stroma. So how do you know that the cells have crossed the border? We know because there is a phenomenon called as desmoplasia, because once the tumor cells invade the underlying stroma, there will be alteration of the stroma. The stroma becomes more fibrous because the tumor cells elicit fibrotic stromal response. That is what we call desmoplastic stromal response. This is what we are talking about. There are these are nothing but glands. They are of very markedly altered contour. Hardly somewhere here we are able to look at or appreciate the glands. They have severe nuclear atypia, very prominent nucleoli, and look at the stroma around. So this pinkish material is the stroma, and the stroma is desmoplastic. Hence, this is an invasive adenocarcinoma. So sometimes you may have this type of signet ring kind of a cell with intraluminal cytoplasm. This is an example of a signet ring cell adenocarcinoma. Sometimes you may not find the typical signet ring cells, and you have this kind of a poorly formed glandular architecture. This is a type of poorly differentiated adenocarcinoma. So there are ancillary techniques that demonstrate overexpression or loss of p53 expression by immunohistochemistry as a manifestation of p53 mutation, and that is helpful in assisting the diagnosis of Barrett's related dysplasia, but it is not always necessary. In case you have a doubt, you can do a p53 immunostain and look at the protein expression. So some mutations result in failed translation of the protein that may result in complete absence pattern, that is loss of expression pattern. So either it can be diffuse strong expression pattern, or it can be complete loss of expression pattern. So this complete loss of expression pattern is less common when compared to the diffuse expressing pattern. So this is what we are talking about. So this is a case of Barrett's esophagus. The normal squamous epithelial lining is replaced by columnar lining, but here there is subtle change in the glandular contours. So in this case, it will be difficult whether to call it as just a columnar cell change, columnar cell metaplasia, or a dysplasia. So in this case, if you do a p53 immunostain, wherever we are suspecting dysplasia, there will be strong nuclear positivity in the dysplastic glands. Now, moving on to other conditions which we encounter in the esophagus. Sometimes we may have esophagitis, and this is a brush cytology from the esophagus. These are large cells, hyperchromatic nuclei, some nuclear molding and everything is there. Highly likely that there is a chance of malignancy, but no, this is not a malignancy. These are nothing but multinucleated cells. There is nuclear molding, that is, one cell forms an indentation over the other, and nuclear margination, that is, the chromatin is at the periphery. This is a biopsy. Again, you can see the central clearing and peripheral margination of the chromatin, multinucleation, molding, and everything. This is a very typical feature of herpes simplex esophagitis. So this is a case of herpes simplex esophagitis. So moving on to the next organ, stomach. The commonly used system for gastritis is the Sydney system, updated Sydney system. So in this Sydney system, gastritis usually has to be reported depending upon the topography, depending upon the morphology, and depending upon the etiology. You give a diagnosis. So you give. So what is the type of gastritis? Classify it into non-atrophic or atrophic. If it is not falling under these two categories, it could be from a special form of gastritis like chemical, radiation, lymphocytic, and so on. Among the etiological factors, there are so many etiological factors, the common being Helicobacter pylori, autoimmunity. So in chemical forms, it could be bile, drugs, and so on. So you have to basically tell the type of gastritis. You have to tell the etiological factor for gastritis so that it helps the clinical setup. So this is a non-atrophic gastritis. The common cause of non-atrophic gastritis is Helicobacter pylori, and the thick black area denotes that where the Helicobacter pylori is more commonly concentrated. So this is the antropyloric region where the Helicobacter pylori is commonly found. Also, Helicobacter pylori produces this type of pattern where it can involve both the antrum as well as the body equally. Whereas if you get a pattern where the antropyloric region is relatively spared and the body is involved, think about autoimmune gastritis. So this is why the Sydney system asks us to take biopsies from at least 5 representative sites. So the A1 and A2 represent antrum. A1 represents one biopsy from the lesser curvature of the antrum. A2 represents one biopsy from the greater curvature of the antrum. And IAA represents one biopsy from the incisura angularis. B1 represents one biopsy from the greater curvature of the stomach, and B2 represents lesser curvature of stomach, and B2 represents one biopsy from the greater curvature of the stomach. Why they wanted to sample incisura angularis is because this is a common site where the pre-malignant lesion occurs first, and at the earliest you can pick up a pre-malignant condition, whether there is any intestinal metaplasia or there is a dysplasia, before it progresses to hydrodysplasia and aneurysm or endocarcinoma. So always don't miss biopsying from the incisura angularis. So in histology, what we are exactly seeing, we are looking at the glands and we are looking at the pathology. Pathology meaning what is the pathology in the glands? What are the type of inflammatory cells, and what etiology you can find? So this is a visual analog scale. You look at it and grade with your eyes. That is called visual analog scale. And antral atrophy, it can be normal, mild, moderate, and marked depending upon the loss of glands in the antrum. Similarly, in the body, the atrophy or loss of parietal epithelial cells can be either normal, it can be mild, moderate, or marked. When there is any intestinal metaplasia, you just mention how much intestinal metaplasia is there, mild, moderate, or marked intestinal metaplasia. So again, the type of inflammatory cells you gives us a clue. Neutrophils, presence of mononuclear cells usually is associated with Helicobacter pylori. You say if the neutrophils are reaching up to the surface, there is marked activity or severe activity. And if it is just restricted to the epithelium, but it is more, you call it moderate activity. So basically, the presence of neutrophils indicate activity. Okay. And mononuclear cells, usually you look at the lamina propria. So whether there is moderate, whether there is mild or marked lymphomononuclear infiltrates. This is so whenever you see a description, when we write these things, we mean only these particular things, what we have seen. And similarly, Helicobacter pylori, you can say mild, moderate, or marked Helicobacter pylori infection is there. So this is one typical example of a Helicobacter pylori gastritis. So these are all spiral forms of Helicobacter pylori. A good H&D stain will easily pick up Helicobacter pylori, and if you look at this visual analog scale, this will come in the marked or severe Helicobacter pylori infection. So this is a case of Helicobacter pylori gastritis. So as I said, the next common pattern is an atrophic pattern of gastritis. See here, these are the gastric glands. And if I say this is from the body, we are unable to look at the parietal cells. So there is severe loss of parietal cells. And here you can see the goblet cells, which means there is also intestinal metaplasia. So this is a severe form of atrophic gastritis. But what we are seeing here, we are seeing some small clusters of cells which are randomly distributed. When you do synaptophysin, chromogranin immunostains, these cells are small lists of cells are strongly positive, indicating that there is neuroendocrine hyperplasia, whereas K67 labeling index, it's a nuclear stain, doesn't highlight any of these neuroendocrine hyperplasia. So this is a typical case of autoimmune metaplastic atrophic gastritis. It is autoimmune because, as you can see, even in histology, there is loss of parietal cells. Most likely etiology is autoimmune gastritis. Metaplastic because here there is intestinal metaplasia and there is no parietal cells at all. So it has become metaplastic. Autoimmune metaplastic atrophy. So the loss of parietal cells and loss of glands indicate atrophy. Gastritis. So everything put together, you can you can call it autoimmune metaplastic atrophic gastritis. And in this case, there is neuroendocrine proliferation, but sometimes this can result in a florid neuroendocrine neoplasm or a neuroendocrine tumor. So that is the most important thing. In sometimes you can also get an invasive adenocarcinoma because you have an intestinal metaplasia. So in an autoimmune metaplastic atrophic gastritis, the problem is either you are going to apart from vitamin B12 deficiency, it is a pre-malignant condition because it may progress to either a neuroendocrine tumor or it is going to progress to an adenocarcinoma. So we need to be careful. Sometimes we may also see a lot of neutrophils, ulceration, but here in the unlike the previous biopsies, there is marked gastric gland distortion. So this is along with the activity, but in this case, we didn't find any Helicobacter pylori. So this was a chronic active gastritis with severe loss of architecture of the glands. No ATP or anything. This was a case of, again, here you can see there is severe loss of architecture of the gastric glands, but the polarity is maintained. So this is not a malignant condition, and this is not H. pylori or autoimmune gastritis. So this was a case of typical Crohn's gastritis. Again, in this case, you have in the lamina propria, you have marked inflammation, lymphocytes, you have mononuclear cells, you have neutrophils. But again, this is not a H. pylori, this is not a Crohn's disease. Okay, and this is not an atrophic gastritis. But instead, here we have some refractile material. Here it is appearing orangish or yellowish brown or something. You do a special stain, pearl stain. Pearl stain is a stain which stains iron. This dark blue iron stain indicates that this patient has been taking iron pills. So this is a typical case of iron pill gastritis. The only thing you need to do in this case is stop the oral iron and replace it by other iron formulations. So the gastritis will get automatically reverted back. Sometimes you may have lesions which may completely replace the normal stromal components, and you find just gastric glands which are here and there scattered, mostly replaced by these atypical lymphoid cells. This is a CD20 immunostain which stained these atypical lymphoid cells as strong positive. This was a case of diffuse large B-cell lymphoma. So starting from inflammatory conditions, you get even frank neoplastic conditions. Adenocarcinoma I am not discussing because I have already discussed in the esophagus. Similarly, adenocarcinoma you can get in the stomach from pre-malignant conditions. In certain conditions, you may get a polypoidal lesions in the stomach. And when you sample, you find this kind of a spindle cell tumor positive for DOG1, c-KIT, and H-calrase1 immunostains. So why I want to highlight DOG1 and c-KIT is DOG1 and c-KIT are positive in gastrointestinal stromal tumor, whereas H-calrase1 is a non-specific marker which also stains smooth muscles. So when you do only this one particular stain, you can falsely call it a leiomyoma, but it is not a leiomyoma because when you consider H-calrase1 positivity along with the positivity of a panel of markers from DOG1 and c-KIT, you can clearly say that we are dealing with a gastrointestinal stromal tumor. And gastrointestinal stromal tumor is a malignant condition, unlike leiomyoma, which is benign. So the prognosis is completely different. So moving on to the small intestine, the major indications for small intestinal biopsy in routine practice are malabsorption, iron deficiency anemia, diagnosis or monitoring of gluten-sensitive enteropathy, that is celiac disease. But here in our setting, celiac is almost rarely seen. Whereas in my center where I did my DM and MD from PG Chandigarh, we used to get around, at least one case per day. So celiac disease was very common there. So other than that, very rarely we get indications such as ulceration induced by drugs, or in cases where you don't know the cause of the bleeding from an unknown site, the small intestine will be sampled as a part of the diagnostic armamentarium. And finally, sometimes there is a tumor site which needs to be sampled, and you need to know the type of tumor for further management. So this is one rare case. So I'll be showing you rare cases because you may or may not see these cases again. So if you see this on the right side, so these are all normal enterocytes. So normal enterocytes will have a single layer of cells with regular oval elongated nuclei. These small hair-like structures along the surface are the brush borders. So when you find brush border, it indicates that you are in the small intestine. Okay. Whereas in this condition, you see the normal eosinophilic appearance is completely altered by these vacuoles which are transparent, or it is containing something which is not stained with eosine. So this fat-containing enterocytes are typical of hypobeta or A-beta lipoproteinuria. So these patients again are usually young patients. They present with chronic diarrhea. Unless carefully looked for, this condition may be missed. So this is again another condition as a cause of chronic diarrhea. You find the brush border of the enterocytes. These are goblet cells. Goblet cells are normal part of small intestine and the large intestine. Whereas here you find some structures. So these are structures which are pear-shaped. They have nuclei. They have also flagella. So these are typical giardia. Usually giardia comes in clusters. So this is a typical case of giardiasis causing malabsorption. This is another case. Here, this is a normal small intestine villi, normal goblet cells, normal enterocytes. Intraepithelial lymphocytes are normal. So you call an increase in intraepithelial lymphocytosis if the intraepithelial lymphocytes exceed at least 25 intraepithelial lymphocytes. Okay. Here, everything looks almost normal. Here is a lymphoid follicle, but this is not normal because normally you should find a lot of plasma cells in the lamina propria. In HND, I was not able to find the plasma cells in this condition, but the patient had diarrhea, but villus is normal, there is no giardia, there is no increase in intraepithelial lymphocytes, the enterocytes appear normal. So what is the etiology? You do a CD138 immunostain. The CD138 immunostain highlights the normal epithelial cells as well as plasma cells if they are present. But here you don't find any plasma cell in the lamina propria. So in this condition, you don't have plasma cells. So what is this condition? This is a common variable immunodeficiency. So even genetic conditions can be easily diagnosed based upon morphology. And if you are looking at carefully, you do IHC and you can pick up common variable immunodeficiency in a biopsy. Again, this was a case where again this patient presented with chronic diarrhea, had multiple opinions, but again the villi is normal, intraepithelial lymphocytes are normal, plasma cells are there, so everything looked normal. But you did a congruent stain. Congruent showed this acellular material, which is congophilic, also present on the vessel walls. So the same congruent stain, when you visualize under polarized light, it will give apple green birefringence. When you visualize under fluorescent light, they will appear red, typical of amyloidosis. So amyloidosis again can easily be missed on a biopsy. So this is another condition where the architecture is gone. There are a lot of cells with plump cytoplasm, and they contain something. So this was a post-transplant case, post-renal transplant. Patient had chronic diarrhea. This was a duodenal biopsy. What you are finding here, you are finding these are all histiocytes, and the histiocytes are containing multiple intracellular organisms. So these intracellular organisms have a pseudocapsule around at places. They are also showing budding. So this is a PA stain. Again, it highlights these organisms very crisply. And once they show budding and this type of typical morphology, it is nothing but histoplasmosis. So this is a case of histoplasmosis in a post-transplant, post-renal transplant biopsy presenting with diarrhea. Right. Here, this is nothing but a cell cluster, regular cell cluster with regular uniform nuclei, salt and pepper chromatin, moderate to abundant eosinophilic cytoplasm. Synaptophysin showed strong positivity in these cells. Chromogranin again, strong positivity in these cells. INSM1, this is an immunostain, which is a nuclear stain, again strong positivity in these cells. This is the case of neuroendocrine tumor. So neuroendocrine tumor commonly occurs in small intestine, especially at D1 or at pylorodial junction, or in the case of an atrophic gastritis, usually it occurs in the body. So finally, coming to the ileum, this is a case of granulomatous ileitis. When you get a granulomatous ileitis, do a Z-Nielsen stain and look for acid-fast bacilli. So this is an acid-fast. See, in this whole field, you are finding only one bacillus. So even a one bacillus, you have to search for that bacillus because it is going to completely change the course of the patient. If you say it is positive, it is going to be treated as tuberculosis. Although if it is a negative, if it is negative, it is going to have a lot of differential diagnosis. But once you say Z-Nielsen stain is positive, patient is going to be treated as tuberculosis. This is a case of intestinal tuberculosis. So we'll move on to the large intestine. So why commonly large intestine is being sampled is again there are various disorders. Sometimes both the endoscopy as well as the biopsy may look normal, and sometimes they look abnormal. In abnormal, usually there can be inflammatory disorders or that can be infiltrative disorders. So there is a list of conditions where there can be inflammation, which can be depending upon what type of cells, neutrophilic, eosinophilic, lymphocytic, or so on. There are various differential diagnoses. So this patient presented with again chronic diarrhea. These are the normal colonocytes, but here, as I said, small intestine will have brush border. Large intestine is not going to have brush border. See, these are all brush border like organisms. Look at these organisms. These organisms are blue. I call it a blue fringe. So in the previous slide, this is a small intestine, look at the normal brush border, they appear pinkish. Okay, whereas these are appearing bluish. So there is something abnormal because large intestine is not supposed to have a brush border. And if you are getting a brush border, it should look pink, but here it is looking blue because this is a typical case of intestinal spiroketosis. So these are all spirochetes in the large intestine. So this is an intestinal spiroketosis. Sometimes you may get acute blood with mucus. It may be biopsied because clinically there will be a differential between inflammatory bowel disease and infectious causes. So you have to look carefully for infectious causes. In this case, you are finding large organisms with nuclei. There is these red cells are nothing but RBCs. So these cells are eating up RBCs. Called as this phenomenon is called as erythrophagocytosis. So there are organisms eating up RBCs as well as even some of the lymphocytes. So these are eating up blood cells. So this is a special stain, Mason's special stain. These are all organisms eating up red blood cells. So the red blood cells are easily highlighted as red in the Mason's stain. So these are nothing but trophozoites of Entamoeba histolytica, which are showing erythrophagocytosis. So this is an entamoebic colitis. This is another condition. Again, a patient presented with blood and mucus. Okay, but here you don't find any organism. Whereas in the lamina propria, you are finding less cells. It appears more pink, which means there is more stroma or hyalinization or fibrosis compared to the cells. The crypts are widely spaced. They are looking very, very small. Okay. But you don't find any neutrophils or anywhere inside causing cryptitis or something. In another section, you find the thickening of the basement membrane. Okay. So this is a Mason trichome stain. So there is excessive collagenization of the basement membrane as well as in the stroma. This is an acid fusion orange stain. Again, the thickening of the basement membrane, collagenization of the stroma. So this patient was an elderly patient, had history of diabetes, hypertension, coronary artery disease, and so on. So typically, this was a case of ischemic colitis. Again, ischemic colitis can mimic inflammatory bowel disease, can mimic infectious colitis, and so on. Again, so the management will be different depending on what you sign out in the biopsy. So this is one common case which you usually encounter. Like for example, you find these are normal appearing mucosa. You find ulcer. Normal mucosa. This is a pseudo polyp. Okay, dense inflammation here. See, this is an ulcerated area. If I say this is colon is not supposed to have villi. So whenever we find villi in colon, it is called as villiform transformation. And hardly you are able to see any cells with mucus. So here there is mucodepletion on the surface. There is branching. There is basal plasmacytosis. Basal plasmacytosis is nothing but dense aggregate of plasma cells above the muscularis mucosae. So on a higher power, you find the cryptitis. What is cryptitis? There is infiltration of the crypt epithelium by polymorphonuclear leukocytes or neutrophils. So these are three lobes. So neutrophils have three lobes. So these are nothing but neutrophils within the crypts. And once they get inside the lumen, you call it cryptapsis. When they're confined within the crypt epithelium, you call it cryptitis. That is the only difference. Sometimes you may find, just like your Barrett's in colon, you may find Paneth cells. Paneth cells are supposed to be present in the small intestine and proximal part of large intestine, that is cecum and proximal portion of ascending colon. If I say this is left colon, and normally Paneth cells are not supposed to be present. So this is a case of Paneth cell metaplasia, indicates chronicity, a typical case of ulcerative colitis. So this is another case where you find that this typical non-necrotizing ill-formed microgranuloma. And normally the pyloric glands are not supposed to be present in the small intestine or large intestine. So when you find pyloric glands here, it is considered pyloric gland metaplasia. So a non-necrotizing granulomatous inflammation with palliative metaplasia most commonly you find in Crohn's disease. So in an IBD, your interpretation of the pathology is not only sufficient, but you need to look at other features if they are present. Here you are finding these large cells, which are huge or cytomegalic cells with prominent eosinophilic nuclei. Sometimes they call it an owl-cell-like nuclei. Or sometimes you may not find anything specific in morphology. When you do a CMV immunostain, you find these cells getting highlighted. So there can be even a single cell, which may be missed up in H&E stain that can be picked up in immunohistochemistry. This is the case of typical case of CMV colitis. So with this, I would like to complete my presentation.